Good morning or good afternoon, and welcome to the DiversityRx Your Voice webinar series. This is a monthly series on how good practice, policy, and research can improve healthcare for culturally diverse populations, sponsored by the California Endowment. DiversityRx, since 1997, has been involved with policy development, research, education, and support for healthcare providers, policymakers, researchers, and advocates working to improve healthcare for minority, immigrant, and indigenous communities. You can find out more about our work at DiversityRx.org on the Class Talk listserv or DiversityRxConference.org/yourvoice. Today's agenda: 2 tablets, pero cuándo, addressing language barriers in the pharmacy. First, there's going to be a brief introduction, and then we will have 3 presentations during this webinar, and then we will follow up with a question and answer period, and then closing remarks. For the Q&A portion for the entire broadcast, the audience will be muted, and you may submit questions at any time using the questions window at the bottom of your control panel. If you have a particular presenter you'd like to have your question go to, please note that in your question. To send a question or resource or a comment to the organizer, please enter it in the questions pane, which we're showing you here, and we will forward questions to presenters and try to answer as many as possible. Keeping track of the GoTo Webinar control panel. The control panel that you see on the right of your screen can sometimes disappear on you. If you select View from the drop-down menu and make sure the Auto Hide the Control Panel is not checked, that will keep the panel in your vision and make you able to ask questions. So today, it's my pleasure to introduce Nisha Agarwal, who is the Director of Health Justice at the New York Lawyers for the Public Interest, NYLPI, where she focuses her efforts on bringing a racial justice and immigrant rights perspective to healthcare advocacy. Nisha is currently representing a Latino community-based organization in a legal and legislative campaign to make pharmacies more accessible to limited English proficient individuals. She is also representing a coalition of 40 community and faith-based organizations in the Bronx in a campaign to eliminate segregation on the basis of race and insurance in New York City hospitals. She received her JD from Harvard Law School in 2006. Nisha.
Hi, thanks so much. I'm so pleased to be able to participate this afternoon. As was mentioned, I'm the Director of the Health Justice Program at New York Lawyers for the Public Interest. And what I thought I would start with today is just tell you a little bit about NYLPI, and in particular our history with language access work, which I think provides a good frame for the work that we've done specifically on language barriers in pharmacies with another organization here in New York called Make the Road New York. And then finally, I wanted to conclude by talking about a few of the outcomes that have come from our advocacy efforts and some of the future goals and campaigns that we hope to be involved with in this area. So starting first with New York Lawyers' mission, New York Lawyers for the Public Interest is a nonprofit civil rights law firm, and we are based here in Manhattan in New York City. And one of the things I think that's important to emphasize about our model, which is really kind of shapes the advocacy we've done in language access, is that we have an approach called community lawyering. And what that means is that we represent community-based organizations and multifaceted campaigns on all of the issues we work on, racial justice and disability rights related. The Health Justice Program in particular focuses specifically on eliminating racial discrimination, anti-immigrant bias, and language barriers in the healthcare system in New York City and New York State. Our history with language access goes back almost 10 to 12 years now, when we started working with key partners in the New York area like Make the Road New York, the New York Immigration Coalition, and others on language barriers issues, particularly in hospitals. And what we would do is work with community members to gather their stories and testimonies, and usually work with our state attorney general's office to work on civil rights complaints against hospitals. These efforts resulted in settlement agreements with a number of hospitals in the New York area, and I think really contributed to new state hospital language access regulations that were promulgated in September 2006 here in New York that significantly clarified and strengthened the rights that LAP individuals have in the hospital setting. Our pharmacy work really grew out of the work we've done on language barriers in hospitals. And in particular, we started working on this issue in about 2007. And the work really emerged out of a confluence of a number of different factors. The first and foremost being, of course, that community members began stepping forward and reporting that they were experiencing language barriers in the pharmacy setting. So as a result of a lot of our hospital work, we were able to do a lot of community education and outreach so that LEP patients understood that they have rights to interpreters and translated documents in the healthcare setting. As a result of this, we saw community members stepping forward and saying, it's wonderful that I can go to the hospital and get an interpreter and understand what's happening there, but the minute I take my prescription to the pharmacy, I'm given 3 different medications and I don't know how to take them appropriately. And we were hearing some pretty horrific stories about experiences that patients were having, either caring for themselves or for their children or other family members. Around the same time that we were hearing these stories in 2006, 2007, the New York Academy of Medicine also released a study on medication label translation and found actually that the vast majority of pharmacies in New York City, and they did a pretty extensive survey, were not providing the translated medication labels that would be needed for LEP individuals to understand their medications properly. So these two pieces then combined with a third, which was important for our advocacy efforts, which is that we had a new ambitious Attorney General who significantly expanded his Civil Rights Bureau. And looking at all these factors together and our historical experience working on hospital language barriers issues, we decided to tackle the problem of pharmacies and language barriers in pharmacies. Our legal approach, I'm sure most of the folks on this call are generally familiar with Title VI of the Civil Rights Act and how it relates to language barriers. It's worth mentioning that the Supreme Court case of Alexander v. Sandoval prevents litigants, such as the community groups that I represent, from actually going to court to enforce their rights under Title VI for cases like language access. And so we've had to look to government agencies to enforce this law. At the time that we were looking into the pharmacy work, the federal civil rights branches didn't seem like they would be quite as receptive to our claims, but we'd had a previously good experience with the State Attorney General's office, and as I mentioned before, we had reason to believe that the new AG would be also interested in working with us to pursue civil rights enforcement. So we went ahead and used Title VI as one of the bases for the legal approach to our campaign. We also actually looked at state education law, which is where our pharmacies in New York are regulated, and looked specifically at our counseling and labeling provisions. New York State is somewhat unique in its requirements that counseling must be provided to patients when they are first filling a prescription or when prescriptions are being renewed. And that, we felt, gave us some leverage to be able to make the argument that if patients are required to receive counseling from their pharmacist, then if they're not receiving an interpreter during that counseling process, that the counseling provision itself is in a way being violated. And the same is true for our labeling provisions, which require that the medication labels be understandable to an ordinary user. And our argument was that if the label is not translated, then again, that provision of the education law is being violated. And it's possible Dorina, the next presenter, will be speaking about this a little bit, but I know the National Health Law Program is actually doing a survey of state pharmacy laws that would sort of compare and contrast how, for example, New York's approach may differ from those in other states. Finally, we also, in New York City, are lucky to have a very strong city human rights law, which very much mimics Title VI of the Civil Rights Act. And so on that basis, we also alleged violations of the city human rights law. What we did sort of practically was that we combined all of the testimonies and stories that we're hearing from community members into a formal complaint to the Attorney General's office. And we also provided to the Attorney General's office, we tried to be as helpful as we possibly could, and also provided proposals for adequate remedies and consulted with a range of groups from the New York Academy of Medicine to the National Health Law Program to other experts on sort of the provision of language services to inform the AG's investigation and ultimately any remedies that they would pursue. And, I think one of the lessons learned from this process is that we had to keep inserting ourselves into the advocacy and into the work the AG's office was doing so that it wasn't just that we found a favorable outcome in terms of enforcement of the law, but that actually the resulting remedies were done in a way that made sense and was practical and pragmatic. Critical to our efforts in the pharmacy area was having a community organizing and a community mobilization piece, and connected to that, of course, was outreach to the media. So all of the we actually filed multiple iterations of our complaint as more and more complainants stepped forward, and each new filing was accompanied by an action of some sort in the community in front of a pharmacy that wasn't providing language services. This not only served to keep pressure on pharmacies, but it also, frankly, kept pressure on the AG's office because it was a reminder that we're still there, we still want you to investigate our complaint, and it really allowed the pace of the investigation to move forward quite quickly. Critical also to our work was doing a lot of Know Your Rights and community education about language access in pharmacies so that more LEP individuals would step forward and be able to say that, you know, I was not provided an interpreter when I went to the pharmacy, and they would report their situation and be able to participate in the campaign as well. And then finally, we did extensive media outreach to local, ethnic, national press, all sort of venues, radio, print, and TV. This served a critical public education function again, and also, frankly, allowed us to shape the message in terms of how these issues are talked about in the public, and so that a sort of positive theme, a public health theme, came out as opposed to an anti-immigrant or anti-LEP theme. And I just, you know, before I move on from this slide, I cannot emphasize enough how important the community piece was here and how critical it is for anybody who wants to do work in this area, whether you're a provider or a community organization or an advocacy organization, to really put the energy into mobilizing people so that they have their own say and ownership over the campaign. Finally, the sort of community piece was leveraged into a legislative advocacy effort as well. We were able to achieve settlement agreements with all of the major chain pharmacies in New York State, which affected some 2,000 stores and 2 million LEP individuals across the state. But the media piece also attracted a lot of attention of local elected officials who wanted to be able to introduce legislation that would ensure that the results of the settlement agreements were actually codified and sort of in perpetuity, that you would have pharmacies complying with the law beyond the term of the settlement agreement. So we worked with local elected officials, in particular the city public advocate, to introduce a local city council bill, and worked closely with the elected officials to draft legislation and negotiate and lobby for it. So that, you know, that effort continued kind of parallel to and sort of dovetailed with some of our enforcement work. And ultimately, I'm quite pleased to say that we were able to, as I mentioned before, reach settlement agreements with some 2,000 different stores across New York State on language access in pharmacies, and all of the settlement agreements and fact sheets about what they contain are included in the resources that I think were shared with the participants of this call. Also pleased to report that September 3rd, 2009, Mayor Bloomberg signed the Language Access in Pharmacies Act, which affects New York City, the 5 boroughs of New York City. And perhaps during the Q&A, if folks are interested, I can walk you through some of the key differences between the settlement agreements and the law. They're not exactly parallel to one another, but similar enough in terms of providing interpretation services and translated documents, or translated labels and things like that for LEP individuals. And finally, I think the fact that we're having this call, we were also thrilled to hear after these victories from advocates in other areas and also from pharmacies and other providers who were very interested in wanting to replicate some of this work in their own jurisdictions, and very much look forward to speaking with folks on this call about ways that we could work together. Finally, I'm going to just flag that we're looking now at the state level to do broader patient safety work, such as medication label standardization, and also just trying to codify some of these language access achievements that we had at the city level and codify them at the state level as well. But happy to answer any questions, and my contact information is there if folks would like to follow up with more offline.
Thank you so much, Nisha. Now we are going to have, and we're going to have time for all questions and answers during the question and answer period, but we want to have time for each of our presenters to do their presentation, and then we'll take questions. And I see that some questions are already coming through, so thank you very much. Dorina Wong is a senior attorney at the National Health Law Program, NHELP, which is a national public interest law firm working to increase and improve access to quality health care on behalf of limited income people by providing legal analysis and representation, information, education, and policy advocacy. She provides support to the Health Consumer Alliance, a partnership of consumer assistance programs operated by community-based legal services, whose purpose is to help low-income people obtain essential health care. She places a special focus on increasing the provision of culturally and linguistically appropriate healthcare services for immigrants and limited English proficient populations. She graduated from New York University School of Law in 1987 as a second career after having worked as a healthcare professional for 9 years. Dorina, thank you.
Okay, thank you. Thank you very much for that lovely introduction, Candace, and thank you for others at DiversityRx for inviting me to present today. I'm very excited about talking about language barrier, addressing language barriers in the pharmacy context. I just wanted to have a couple of issues or caveats before I start. Just for those of you who have not heard of the National Health Law Program, we're a nonprofit public interest law firm working to increase access to health care on behalf of limited income individuals, I think Candace mentioned, especially children, women, elderly, immigrants, limited English-speaking populations. We do that through litigation, advocacy, policy expertise, and we've gotten involved in the area of language access for many years now and have a lot of resources on our website, and I put a couple on the last slide of my presentation. And as Nisha, alluded to, we are going to try to come out with a 50-state survey very shortly within the next couple of months so that you can go ahead and look up and see what your particular state requirements are. And with regard to that, that's my second caveat. I'm not going to go into the legal requirements specifically. I'm going to focus my presentation on what's happening in California around a new bill that was passed in 2007 that is kind of a unique one of its kind and that other states are looking to. But I'd be happy to talk more about what the other legal requirements are. And it's also the issue brief that was put on as a resource on the DiversityRx link. There's a link to a very good issue brief around what the requirements are, at least around, as Nisha alluded to, referred to Title VI. Anyway, so I wanted to also just quickly talk about language barriers in the pharmacy context because, as you know, limited English proficient patients face language barriers when they're trying to understand how to safely take medication. And so, let's see, I'm trying to move my slide along, but for some reason it's not moving along here.
Dorina, this is Ann. Would you like me to run your slides for you?
Yes. Could you just move it to the next one? Thank you.
I can do that. Hold on, folks,
great.
just a moment.
Is it on everybody's screen at the moment?
I'm going to go ahead and so I will run your slides, and you can just prompt me when you'd like to move to the next.
Okay, and also, can you hear me okay?
Yes, we can.
Okay, great. So, as I was saying, a limited English proficient patient's inability to understand medication labeling and instructions, I think we all easily can see that it could cause errors, not only in usage but seriously endanger the patient's life. And the Institute of Medicine has identified medication errors as among the most common medical errors. It harms at least 1.5 million people every year. Thank you very much. And at least up to 1/2 of all medications are taken incorrectly or mixed with other medications that cause dangerous reactions. Next slide. And almost half of all adults cannot understand the label on their medication. At least 6 out of 10 actually take medications incorrectly. Next slide.
Dorina, we're on the medical errors slide. Is that where you'd like us to be?
Oh, what the strange thing is, I guess what's happening is mine is not tracking. Okay, no, can you go back one slide?
Language barriers and pharmacy content.
Yes, thank you. So there's more than 4 billion prescriptions that are written yearly, and out of that, since the LEP population has been estimated to be close to 9% or 8.7, that means that millions of prescriptions are likely written for LEP patients. So actually there's been a study that has shown that 25% of patients who need an interpreter but did not get one did not understand their medication instructions. And this compares to only about 1 out of 50 or 2% who did receive an interpreter and or did not need one. So you can see that it's a serious problem. Next slide. And then in terms of the medical errors, I just wanted to point out a couple of examples. I don't know if folks have heard about it, but there was a 6-week-old infant who was admitted for a barbiturate overdose because the mother did not understand how to use the medication and gave her baby a 10-fold medication dose, and that required hospitalization. And we know of another, actually, lawsuit that happened in Fresno County because a law woman who is incarcerated for 10 months because she stopped taking her TB medication because she was never provided an interpreter, despite the fact that she requested an interpreter and was not able to get one. So next slide. And so I think California recognized the importance of reducing medication errors and the importance of increasing healthcare literacy around prescription drug labeling, and passed SB 472 in 2007. That requires the Board of Pharmacy to issue regulations to design and implement, and this is important, is a standardized patient-centered prescription drug label. That's for all prescription containers, and this is supposed to be done by January 1st of 2011. This is a first of its kind in the country, and many other states are looking to California for this. And then by January 1st, actually, of 2010, they're supposed to report to the legislature on their progress. And then by January 1st of 2013, the status of the implementation of this drug requirement. Next slide. In terms of what the board has to take into account, there's several different factors that, and I think that this is important because I think the legislature recognized that you have to look at lots of different issues. One is the medical literacy research that is supposed to support increased understandability of the labeling. One is improved directions for use and improved font types and sizes to increase legibility so that you know, the tiny little, trying to read the tiny little writing and instructions is sometimes hard, especially for seniors. Also, the placement of where that information is placed, and then also relevant for us is they had to actually take into account the needs of patients with limited English proficiency, and again, the needs of seniors. And then finally, the technology requirements necessarily to implement these standards. And as we'll get into a little later, you will see that some of the technology requirements, you know, some of the pharmacists may claim that that is a barrier, but I think that those technology barriers or challenges hopefully can be addressed. Next slide. Now, the Board of Pharmacy also had to work with many stakeholders, and so they conducted hearings throughout the state to get input and testimony from all stakeholders. That would include, you know, patients and pharmacists, other providers. They also did a needs assessment survey to actually find out what the needs of patients were, and they did translate that into Spanish. That was the only language that they did try to gather information in. So a lot of the advocates, including our organization, actually organized different affected populations. And so some seniors groups and some language access advocates brought together LEP patients to the hearings to testify about the need for translated labels into non-English languages. And finally, in the summer of 2009, some proposed regulations were shared with the public at one of the Board of Pharmacy hearings, Actually, all along, many stakeholders were testifying, but at this particular, the July and August 2009 meetings, we were the board was met with some resistance from some of the pharmacy associations. Next slide. The proposed regulations, that the Board of Pharmacy came up with, required things like the patient name, the name of the drug and strains, purpose, and directions for use to be printed in one certain area so that patients would know where to look. Also, it is supposed to be printed in at least a 12-point sans serif typeface to make sure that it's legible. And it also proposed some standardized directions, 17 specific directions on how much medication to take and how often to eliminate confusion. So that would be like take 1 tablet at bedtime or 3 tablets at bedtime or 1 tablet in the morning. So 17 kind of combinations. And these 17 directions are supposed to be translated into the 5 most common languages and then posted on the Board of Pharmacy website. Next slide. And the last couple of provisions, regulations, had to do with the instructions. If the instructions didn't conform to these 17 directions, the pharmacy would be responsible for securing and doing its own translations. And then for patients who could not read English or could only read in another language, upon request, the pharmacy could provide a translated. The pharmacy had to provide a translation of the prescription. Next slide. And then, so I wanted to just then talk a little bit about the final proposed regulations, which is slightly different than what the proposed regulations were, because at the October 2009 hearing, the Board of Pharmacy accepted some of the pharmacists' arguments and agreed to some changes and weakened them. And then they came out with their final regulations just last month in November, and now our written comments are due on January 4th of 2010, and then we could also testify. We are planning on testifying at their next board meeting on the 20th of next year. So the final proposed regulations, next slide, they basically accepted the first 3 provisions and changed the last 2. So what will be happening is they will translate the 17 directions, but it'll be posted in October of 2011, but there will not be a mandatory requirement of pharmacists to translate the information. But the LEP patient can request an oral translation of the prescription container labels information in the language of the patient. So hopefully, because there is also a similar counseling requirement as there is in New York that Nisha was referring to, the oral interpretation is going to be required. And then I'm just going to end with just a mention of the OCR settlement. I wanted to let folks know that, because this may affect, this is on the next slide, this may affect others nationwide, because on June 15th of 2009, Medco agreed to improve access to pharmacy services for its LEP members, because Medco is the nation's largest mail-order pharmacy and benefit management company. Many health plans contract with Medco and who administer the prescription drug claims of many health plan members. Next slide. One of their Spanish-speaking members had trouble and was not provided with an interpreter and was left messages in English, and her prescription requests were canceled. So as a result of that, there was a resolution agreement that parallels a lot of the other Title VI. The Office for Civil Rights, which is the enforcement agency in the U.S. Department of Health and Human Services, enforces Title VI. And the OCR came up with an agreement with Medco, and these are, I just listed some of the settlement agreement, the terms of the settlement agreement for you to look at. And as I say, it parallels a lot of what is required for providers in other contexts. And so, I'll be happy to talk more about that at the end. And then the last slide is just, again, a mention of some of our resources. So I know that was a little bit quick, and I hope I'm looking forward to answering any of your questions when we have a chance at the end. Thank you.
Thank you, Dorina. And we actually are getting in a lot of great questions. So hopefully we will have time to get to most of them during the webinar. And just so you know, if we don't have time to get to all of them, we will try to get to some of them via email that we'll post to the site afterwards. And I should have mentioned at the beginning that all of the presenters' slides as well as their resource materials are already posted to our website. And now Joanna Ramos is going to be joining us. She has her MSW, and she's the director of the Washington Coalition for Prescribing Integrity, a small coalition of health, consumer, and civic groups working on the policy level to ensure that all residents of Washington State have access to appropriate and affordable prescription drugs. She's also a member of the Interim Steering Committee for the Washington State Coalition for Language Access, drawing on her background as an independent consultant on domestic and international health equity issues and experience as a medical interpreter. In addition, she serves on the management group of Healthy Skepticism, an international nonprofit organization dedicated to promoting rational use of medicines. Joanna.
Okay, thank you. Welcome to everybody from chilly Seattle this morning. Next slide, please. We have, in Washington, we're a small state compared to New York and California, but we are also part of national networks, and we have our own background here, which I wanted to share with you about, certainly could be replicated in other areas. The Washington Coalition for Prescribing Integrity began with a grant from the Prescription Project in Boston to work on state policy efforts to achieve this goal of access to medicines for everyone and to reduce the conflicts of interest that can exist from pharmaceutical companies on the medicines that we get. This is just important for you to know for background. Next slide, please. And the Washington State Coalition for Language Access began in 2005 with a grant from the U.S. Department of Justice to improve services to immigrant crime victims. And then as it developed, went on to expand to all of the areas of life that affect all of us, and building on our strong community and in advocacy here in Washington. Currently, next slide, please. In Washington State, about 18% of the population speaks a language other than English at home. About almost 2% of the people here are classified as blind, and another 8% as having hearing impairments and or deaf. And as Dorina showed you about national prescriptions, we've probably had almost 60 million issued in our state last year. So this is considerable. You can see that many people need prescriptions, people who have all different communication needs, including the health literacy need, which we also look at. So because we have these networks in place, and I have a foot in both worlds myself, I was aware of what was going on in California and New York, and in fact, I participate in our WASCLA monthly phone calls, as well as ones run by the National Council on Interpreting in Healthcare that I am a member of, and people were asking me, well, what's going on in Washington about language access to prescription medicines for the information patients need? And I said, well, that's a good question. Let me think about this and look around and see. And so we're in the first steps of working on this issue in our state. I'm learning a lot from our colleagues in the other areas, and we are taking our coalition-building approach into this work, both from WCPI and from WASCLA. So next slide, please. What I decided to do was to hold meetings to which all the key stakeholders were invited, and we had a really outstanding response from across the state. We had representatives of both of our schools of pharmacy on both sides of the state, which are both public institutions, our state pharmacy association, legal and immigrant rights advocates, and language providers, whether they're interpreters, some translators, people who work just in the pharmacy area in some of our institutions like Harborview Medical Center that you probably have heard about, as well as community clinics. We have some language and ethnic-specific community clinics and healthcare providers in general. So we're really, our aim was to get everybody at the table and talk about what's going on and where we go next. Next slide, please. And because we recognize that with all of our work on improving access to care for limited English-speaking people, the issue of what happens at the pharmacy hadn't really been addressed yet. We decided we needed to start with a very basic approach to make sure that all the different professions knew how each other operate, because this is often a first-time encounter for all of us. So we explained about, we had dedicated speakers on interpretation, translation. We had the legal advocates explain about the state and federal laws. And we do have, like many states, a state law against discrimination, although this has never been referenced regarding language access to date. We also have a law, as a number of other states do, about the training of healthcare professionals in multicultural competency, and it's on a rolling basis of which professions are included. So, and then there is a counseling requirement for pharmacists that we do know about, and we wanted to hear also to learn for the interpreter community to learn about the training and practice of pharmacists. There have been changes in that, and we were very glad to have people from the schools of pharmacy and the Pharmacy Association explain that to us, how it all works. And we also, we're very open that this is all questions were on the table, and we wanted this to be a collaborative process. Okay, next slide, please. We also are fortunate in our state that we have an excellent program, which, while it's not about provision of medicines specifically, it's about helping people get medicines that they need. It's called the Washington Prescription Drug Program, and I invited them to speak at our first meeting. This is an outgrowth of a purchasing pool for medicines between the states of Oregon and Washington. And a few other states have this as well. It's called the Northwest Purchasing Consortium. And this agency here in our state made it its business to have its outreach materials and telephonic interpreting available for enrollment in 8 languages. And this is a program where any resident of the state can receive a free discount card for buying medicines. It's particularly beneficial for people who don't have any insurance because it can offer up to 60% discounts on the price of drugs at the participating pharmacies. It also can be used by insured people or instead of insurance. And I'm not going to explain to you all the specifics of how this works, but it is really outstanding that they have these materials available, and the telephonic, if you look on their website, you'll see that materials can be ordered by facilities in these languages. They have print materials. And so this is one step ahead that we have here, and it's because they're a state agency, they have been able to use the system that the state has in place for providing language access for clients of state programs. And as you all may know, our state was the first state, and I believe is still the only state that was the first and for a while the only state with certification of interpreters in the 8 most common languages in the state. More about that later, but this has been very beneficial to us to date. Next slide, sorry. So just in a short amount of time that we have been talking about these things, we have seen some positive impact from our work. The State Pharmacy Association is going to be offering a continuing education program on both sides of the state on language access issues. I believe it's in January in Seattle and in April out in Spokane, where the Washington State University's School of Pharmacy is located. There also had been a question about whether or not, because we have this state service for language access in our Health and Social Services Agency, if pharmacies can indeed get reimbursed for using interpreters with patients. And this has been an issue about which there hasn't been a lot of clarity, and we do still need more technical assistance. But one of the participants in our work group, as we're calling it, the Northwest Health Law Advocates, contacted DSHS, and they did get a response that, yes, it's possible if the pharmacies enroll in this project in a certain way. There's a lot of steps, but right now we're going to have to do more technical assistance because the pharmacies would be needing to apparently subscribe to one of the telephonic services, and there hasn't been a lot of information offered about exactly how to do it. We also are promoting resource sharing. WASCLA is developing a new website. Some material is there already, and we're going to have a specific section on language access in the pharmacy. And we already have posted some of the presentations from our past meetings. I also set up another education function where we had this month demos of Meducation, which is a new software program that provides oral instructions in selected languages about specific prescriptions, and also has video tutorials on how to use complex medications such as inhalers for asthma. Next slide, please. So we have our work cut out for us, but we're very glad that we have our colleagues nationally that can help inform us and help us work on strategy. And we are definitely facing challenges because in the current state budget crisis, the governor's budget, following on the recommendation of the Department of Social Health Services, has proposed eliminating totally the language services provided in the new year. And so lots more needs to be done. Obviously, there is a legal requirement that this be done. So it's a work in progress. We're monitoring very carefully, as well as with national health care reform, and many of us participate, of course, in health care reform efforts. And the next step that we're going to be taking in the new year, our next meeting, is we've asked the Pharmacy Association is inviting the representatives of the national pharmacy chains who do business in New York to share with us about what is being done in our state in providing access for patients who come with prescriptions and need language assistance. So the thought I'm going to leave with you is that we like to work on a broad-based approach. We're, like I said, just getting started, so I can't report to you outcomes like have already happened in New York and California, and we're hoping that will be the catalyst for more collaborations to come that will benefit patients. And if you have any further questions, please don't hesitate to get in touch with me. You can see on the next slide the contact information. And I'm here, hope to help, and certainly feel that the efforts that we started here can be replicated in any state. And I'd be as I said, very happy to consult with you about how you might go about that. Thank you.
Thank you so much, Joanna, and thank you all three of you for sharing your time and your knowledge about this with us. We've gotten in several questions, and I'm just going to tell you briefly that the questions seem to be ranging on clarification of the legal requirements, patient safety, technology, costs, accuracy of translations, and which other language, how far this goes in terms of languages, and how the deaf community is being addressed in these things. So let me start with a question for Nisha. And the question is, for purposes of educating patients correctly in the state of Minnesota under Title VI, isn't it true that people, and I'm not sure if you know quite the state of Minnesota, but Title VI I know is federal, isn't it true that people have the right to an interpreter only when receiving services from a federally funded medical provider or pharmacy? Can you just clarify more about that? I believe that was also in the NHealth issue brief.
Sure. So the Title VI requirements, actually, the questioner is right about the federal funding requirement, but the federal funding can be both direct and indirect. So accepting as payment Medicaid or Medicare would make a provider subject to Title VI, which is why a lot of the chain pharmacies and hospitals and other entities that we've worked with have come under the rubric of Title VI. That's because of the indirect funding requirement.
Thank you. Someone also wanted to know, Nisha, about the settlement with Medco and whether you've seen any, if it's affected any of the other pharmacies.
I can mainly speak to New York, and we haven't seen the Medco settlements actually came after our settlements in New York, and so to our knowledge it hasn't affected other pharmacies, though it certainly has affected our thinking on this issue, which is to also incorporate in things like we now have e-prescriptions, and also to look at some of the prescription services like Medco, which are not New York specific, but certainly service New York consumers.
Thank you. Dorina, they're wondering if there are any thoughts about extending this issue to the prescriber of the medication, or actually any of you, but basically to the point where the prescription conversation should begin. So in other words, when the medical professional is writing the script, should there be a mechanism for the health professional to be noting a language need on the prescription? Has anyone looked into something like that? Do any of you know?
Oh, well, that is actually the issue of what is, the challenges of the doctor, say, writing the prescription, and whether or not there's lots of issues around that. They haven't actually talked about a requirement that the doctor should identify the required language, although we would support that. If I don't know if it would necessarily be a requirement, but it would be good if the doctor could help the pharmacist identify that. Although the pharmacists themselves should have some way to identify the language of the patient. There's always the ability to identify a language, at least through a telephone interpreter, and most pharmacists have told us that they do have access to telephone interpreter services. So they should be able to identify the language needed. But in terms of what the doctor's responsibility should do, I know that there was an issue when we were talking about the regulations that some of the pharmacists said that they had to translate just exactly what the doctor prescribed, or the directions that the doctor prescribed. But then other pharmacists said that there was indeed some leeway that the pharmacist could had some discretion in that, and so that those 17, when I mentioned those 17 specific directions, that most, let's say 90% of all prescriptions could be, could be taken care of, at least using some form of those 17 directions, and so. So the remaining 10% might be a little harder to prescribe, but it shouldn't be. So that the issue of how the doctor prescribes, writes out the prescription, shouldn't be that big of a barrier, although I do think we should bring doctors into the mix of all of this as well.
This is Nisha. I'll just pipe in and say one of the things that I zipped through in my slides was that for our state legislative proposals, we actually are proposing that there be a change to the New York State prescription pad, so there is a checkbox where the prescriber can indicate whether a patient is LEP or not, and possibly align to indicate the language spoken by the patient. And that's something that we're putting forward as a way of hopefully connecting the prescriber to the pharmacy. And I'd actually love to hear from folks on the call about whether that's a good idea, bad idea, or specific ways about going about it, because we're really just floating it out there right now as a possible idea.
This is Joanna. One of the things that has been really positive for us, we don't have a solution yet, but because we're building on this the Prescribing Integrity Coalition that includes medical provider groups, most of them were present at our first meeting and are very interested in this topic. And another thing that we saw when we had the demonstration of this Meducation software, and I'm not saying this as a product endorsement just for information, it was developed by a physician named Charles Lee, who is also a bilingual person, as a first-generation immigrant, so was aware of the issue from a personal perspective. So his goal is that the software will be, the logging onto the software will be available to healthcare providers, especially community clinics and so on, where there will be the capability of having the patient view and listen to these instructions and the same as they can get at the pharmacy. And, of course, knowing that many of our patients don't have access to computers at home, they can review the material with their healthcare provider and watch these videos, and if further interpretation is needed or any written translations, the provider also can be in the role of helping to facilitate it. And it will also mean that the provider and the pharmacist are seeing the same instructions being given to the patient and make any type of adjustment. So I will be happy if you want to know how to get the contact information about this, and also about other language service providers. We can, on the technology, and we can let you, all of us can let you know about that too.
Joanna, since you started talking about some of the technology, one of the questions had to do with translation over the Internet versus the translation software that might be available, concerns about the accuracy.
We'll tell you that at the present time, there is no what we call machine translation that can do an adequate job of converting a message from one language to another. And in fact, I recommend, for learning more about this, going to the website of the American Translators Association, and they have an excellent booklet called Getting It Right, which can be downloaded for free from their website, and it will explain. And I have had personal experience of working with agencies and organizations that thought that they were being very economical in using machine, computer software for translation, and then they literally had to pay twice to get it done professionally. And usually a language professional will go through doing a rough translation, and there are software tools that professional translators, and translation refers to rendering of written message from one language to another, and while interpreting is about oral or signed communication, just as a aside. So they do use this, but then they translate it into target language, and then it's back translated to see if it still makes sense with whatever the original language was. So we definitely don't recommend, maybe in 25 years from now there'll be something really great, but humans need to be involved. Professionally trained humans need to be involved. And also, for a lot more, you can go to the website of the National Council on Interpreting in Healthcare to learn more, too, as well as on National Health Law Program.
Great, thank you. I want to make sure we get to this question because it was one of the first questions, which is basically, if any of you could address, if you know how language barriers of the deaf community are being addressed. Are they requiring any video relay services to be accessible while at the pharmacy?
This is Nisha. I'll say that in New York, our efforts focused on LEP communities, and we would welcome involvement and collaboration with folks from the deaf community for our statewide advocacy to expand those efforts to other communities as well.
Right. This is Dorena. The specific legislation in California doesn't really address ASL or sign language interpreters but the fact that it is kind of that it's a patient-centered translated label that the deaf and hard of hearing community should be able to read it and understand it. And I do believe that, and in fact, hopefully maybe some of the participants could actually respond, that most of the pharmacies do have the TTY, the telephone relay services available, and that's part of the issue. The reason why a lot of it's treated a little differently, let's say, for the deaf community versus the foreign language patients, is because it's under different jurisdiction, or it's under different requirements, legal requirements, because for the deaf and hard of hearing, it's under the ADA and Section 504 of the Rehab Act, so there's slightly different requirements, and so that's why it's kind of sometimes a separate track. But I think some of the issues would be addressed if there is kind of a common or a standardized patient label, at least for them to be able to read.
I would just like to add also that this is an area that needs a lot more attention, and I made a big effort to be inclusive of all of our communication needs in planning our work here in Washington State. And in fact, one of our health law attorneys was in her previous life was a sign language interpreter, so we have a lot of contacts. But one thing that surprised me is that although I invited all of the organizations involved with serving deaf and hard of hearing population, no one has come to the meetings yet or responded, and so obviously we have to do more work on this.
This is Doreen again. Yeah, and yes, and one issue that did come up in the discussions around the regulations was having the label in Braille, or for at least for the blind community, people with sight barriers. So there is discussion around how that would be, where that would be placed, and how that would be addressed as well.
Thank you. We have reached the end of the webinar, but we will go ahead and do 2 or 3 more questions, and if you can stay on, that's wonderful, and if you can't, we completely understand. People can continue to go ahead through the questions pane to send your comments or questions or additional resources. There's been a great response to some of this Q&A period, and we will go ahead and share all of your responses with the presenters, and I'm sure that they'll do their best to answer any further questions, and I think this is a great dialogue that's going to proceed. But I feel like we have to ask the big question, which is, are pharmacies allowed to bill for the required language services they must provide, and how are they meeting these requirements? Do any of you have a response for that?
Sorry, I didn't understand the question. I think, is the question that could they be reimbursed for it through something like Medicaid or?
I think that's basically what they're saying, is there's going to be an additional cost involved with a lot of, of making sure that they're meeting the needs of all their patients, and how are they covering those costs?
Right. Who wants to go first? Let me this is Dorena, that the main funding mechanism that some of us are aware of is the Medicaid reimbursement for language assistance services, but only, about 14 states in the District of Columbia, Washington State being one of them, where Joanna's from, it does pay for language assistance services for Medicaid and CHIP beneficiaries, although a lot of the mechanism for pharmacists, as far as we know, have not been set up, but theoretically there should be a way, if your particular state does have a reimbursement mechanism, at least to reimburse Medicaid beneficiaries. A lot of health plans, may cover it. It's not a requirement. I guess we would say that it's part of providing quality health care, and that it's just one of the expenses that one has to take into account when you're trying to, ensure effective communication with your patient. But we are trying to find ways to get these kinds of services funded, but it's probably not adequate at the moment.
I think that's great. There was a question of, sorry, you wanted to go on? Sure.
Just really quickly, and that's another issue that we're hoping to bring a lot more attention to, and I know the pharmacy profession is concerned about this, about how that very few people in the public know that they're reimbursed on like a per script basis, on a capitation basis, rather than on a needs-based basis. And so I'm not going to, I think I've heard it was something like $1 to $3 per prescription. And so there really needs to be a different kind of a focus on media's Dorina said, about meeting the patient's individual needs, and that's why there are efforts underway to require insurance companies, if operating in a specific state, to cover language services, and thinking about some other ways that this could be funded. But yeah, a lot more needs to be done.
I'll just sort of add here that I think that this is such a tricky issue, is figuring out how to do the funding, and I think certainly as advocates we try to be very pragmatic on this issue. So I do think that sort of underlying the legal requirements, and particularly Title VI, is the theory that when an entity like a pharmacy chain gets federal financial assistance through Medicaid, Medicare, or other streams of funding, they're essentially accepting taxpayer dollars and cannot exclude any of the taxpaying public. And so that's the kind of trade-off here in terms of getting the public taxpayer dollars, is also that the discrimination cannot happen. So I think we need to keep that framework in mind, as well as the sort of need to work together to find additional funding sources.
Oh, yeah, I definitely agree, because it has to be just a routine operating expense, just like in the medical provision of medical care.
I think that was a great answer. Thank you so much. And I think, you know what, we will go ahead and we'll end the webinar with that. I have a bunch of other questions that we'll be forwarding to you guys afterwards, but thank you all so much for your time and your expertise on this. And thank you all for being part of this. And if you want to find more information about this, you can go to our website, www.DiversityRx conference/your voice, and you'll be receiving a post-satisfaction survey about this, and we'll be having another webinar next month at the end of January on health literacy assessment. So thank you very much.